1 second, guys. Let me get this figured out. All right, so hopefully you guys see me there. I'm trying to fix the video right now. All right, so let's get started. Hope you guys are having a great Tuesday afternoon here. My name is Garrett McLaughlin. So in this quick webinar, we'll be covering the topic of IT band syndrome and dig into that a little bit more. But this is kind of part of a series that I obviously just started. It's the second webinar in this series, just to cover topics and be able to break those down in greater detail. A lot of the webinars that I host are very general. So these will kind of be short to the point and hopefully provide you a few action steps to again, troubleshoot, reduce pain, improve performance, or just kind of focus on the injury prevention piece when it comes to your running. So glad you're joining me this afternoon. Now, like I mentioned, we'll be covering IT band syndrome or iliotibial band syndrome. This is a review of the research. So as I say that, again, I like to make sure I'm not just throwing out things randomly at you from my opinion and my perspective. Dug into quite a few research articles to put together this information. Some of the stuff that I, again, believe in and use in my kind of daily practice, other stuff that really refuted some of the things as well, which I think is always important to make sure we're respecting the research of what's coming out and staying true to that rather than just always following what we have done forever just because that's the way it is. But just please understand that with everything here, there's always a small degree of bias. So feel free to ask questions, provide feedback, challenge me in some way as we go through here, if there's any additional questions or thoughts on your end. Now, these are a handful of the research studies that I combed through. Just don't want to just say that without showing. So if any of you want to go ahead and look through some of these after the fact, just to see what exactly they say, how were the studies carried out, you're welcome to screenshot this slide and dig into these a little bit on your own if you're interested in that. But focus of this presentation today, we're going to talk about the anatomy of the IT band and surrounding area. One of the most important things I think to start with is understanding what is actually the IT band. What is it attached to? What's its function? This, I think, has led people down a bad path, just assuming that it's just this band of tissue that slides over the quad, that lateral quad and lateral side of the leg. So we're going to kind of talk about that a little bit. Some of the risk factors associated with injury. So if you are someone that either has a history of or currently suffering from IT band pain, what are some of those risk factors that could have potentially predisposed you to pain at that area? And then also, if you're trying to reduce your likelihood of injury, what are those things you need to improve to reduce the chance of suffering from IT band syndrome? Because it can be a pretty irritating and pesky injury to get over. So if we can do the right things on a regular basis within our strength training program, injury prevention program, how do we offset the risk of that? Next up, going into the big question, can and should we stretch it? And I also just about 10 minutes ago, add another slide in on should we foam roll it? Luckily, there are some research studies on this specifically that we'll dig into and talk about because I know most people are wondering, or again, if we suffered from this in the past, hey, how do I stretch the IT band? How do I roll the IT band to release adhesions? But we hear these things all the time. Question is, are they actually true? Or are they things that have run rampant over the years that we just continue to go with, or does it have some validity behind it? And then lastly, we'll end with some rehab and treatment recommendations for the IT band, whether it's rehabbing this or trying to reduce the likelihood of suffering from this injury. What are some specific things we need to do on a regular basis just to stay on top of it? Now, as we get started here, IT band syndrome is typically felt at this lateral portion of the knee joint, right? So this is the outside of the knee. You see these lines here on the right side of your screen. That's where we typically feel IT band pain from IT band syndrome. We can also feel that up a little bit higher at the hip as well. We also can call that IT band syndrome. Sometimes we have some bursitis or glute tendinopathy mixed in with that, but right over where the IT band slides over the greater trochanter, that's another area that we can commonly feel IT band pain. So IT band is this long, very long, one of the longest in the body, longitudinally aligned fascial connective tissue. So you can see we have this fascia that's running pretty much vertically up and down for the most part. It spans from the pelvis, or this is what's called the ilium, right? This kind of semicircular bone here, or the crest of the pelvis, all the way down and actually attaches just below the knee on the tibia. right? Along its root here, it does actually have connections all the way down to the femur. So why that's important is because it's just not this tissue that's on the outer surface that we see. It's not just this white tissue that we see right here and that's it. This tissue actually has attachments all the way down deep inside that thigh bone. So a lot of times, and over the years, it's something, again, when I went back to some of my original, when I started getting into active release techniques, the soft tissue manual therapy, some of the things I was taught was, okay, let's improve how that IT band is sliding on top of the quad, and let's work on relative motion, as we called it. And then as you start to look into the research more, we realize, man, this IT band is actually attached deep inside there to the femur. So it doesn't really slide and glide like we thought it did. It's actually more permanently attached, right? So this is one place a lot of people go wrong, is trying to really work on getting the IT band to slide. It's very hard to prove through the research. There's a lot of new research out there that's kind of starting to debunk that. So we need to make sure we continue to look at that, but not all of a sudden just throw all our eggs in one basket, realize that there's a couple different thought process here. But what we're seeing a little bit more lately is we're not getting that sliding, gliding as much as we thought. It's actually attached into the bone there. As you come down here, we have other attachments down to the shin bone, outside of the kneecap as well. So again, super long tissue. It's important to also see at the top here, this glute, right, our bigger glute maximus muscle, butt muscle, from behind the hip comes down and attaches into that IT band as well as this, what's called the tensor fasciae latae muscle. This is a muscle a little bit more forward in the hip that comes down and fuses right directly into the IT band as well. So up towards the outside of the hip region, we have muscles that fuse directly into that, and we have that long, just fascial tract all the way down from the hip down to the knee. Now, from an injury standpoint, when we talk about IT band syndrome, generally pain right to this lateral portion of the knee. Again, throughout the years, like I mentioned, we kind of had this thought, okay, this tissue is sliding as I bend and as I straighten my knee. This tissue is sliding over, as you can see in this middle picture. Again, we're taught almost that the tissue slides and glides over the outside of the end of the thigh bone there, and underneath there, we're irritating the IT band, we're irritating the bone, we're irritating a bursa. What we're seeing now more so is that between this IT band and the bone is actually what's called a fat pad. So it's just a small layer of fat tissue that's almost like in trying to prevent some type of friction and compression of the IT band on the outside of the leg. Because as we move and as we go in different directions, right, IT band gets closer, IT band gets a little bit further away, but just to try to prevent that consistent compression in there. So what we're seeing a lot of through the recent research is we're actually getting some irritation of that fat pad. There are a lot of different studies to look into this. Some showed that it actually wasn't the IT band in any way that was involved. When people are feeling lateral knee pain or IT band syndrome or suffering from that, the pain or the painful or infected tissue was actually that fat pad underneath, right? It's hard to see, right? And as we evaluate and look at different injuries and things, it's hard to see on the surface unless you're getting an MRI to look at that. But it may not actually be the IT band itself that's the issue, but just the overall, again, those tissues on the outside of the knee, that fat pad a little deeper down, that seems to be what's getting more aggravated in the process when we're suffering from IT band syndrome. Because this tissue spans, I mean, it's huge, right? It's spanning so many different areas, but we predominantly feel pain on the outside of the knee. We need to make sure that we're not automatically assuming this is just a knee issue. Obviously, we need to rule out other things within the knee, meniscal tears, issues with the joint capsule, and other things that could happen at the outside of the knee. But from a biomechanics standpoint, we need to understand the foot. We need to understand the tibia in the lower leg. Is it rotated in or out? Looking at the knee joint, looking at the hip, the pelvis, and the spine. Just because this is such a long fascial tissue, we could have problems in any of those areas, which could actually predispose us to pain here. So not getting you're not getting tunnel vision, as we would say, and looking at this is just a knee issue. How do I treat the knee? Looking above and below and expanding your perspective to make sure you're not missing anything in the process. Now, risk factors for IT band pain, right? So this is more predominant in runners, first and foremost, cyclists, and then any other people performing repetitive movements. Soccer players were listed up there pretty high, who commonly experience IT band syndrome. We need to first look at running. right? If we're talking about this as a running related injury. So did you increase your mileage or your intensity too quickly? Most people always go to biomechanics first. Hey, I'm feeling pain here. What can I fix, rather than this happened after I did this with my running. I changed my surface. I, again, change inclines, declines, a lot of downhill running. I started incorporating speed work. Those are the things we need to go to first. Research shows that about 60 to 70% of all running related injuries are caused by training errors. So not following a proper running program or changing some variable too quickly without allowing the body to build up some tolerance to adapt to that. So that's where we need to look for first and foremost. So distance, do we increase distance too quickly? Do we increase speed too quickly or too aggressively? And then also downhill running. As you'll see, as I'll show in a second, downhill running, as that foot has to come down, because obviously you're running on a slope, that foot's going to land a little bit further down in a more extended knee position. There's a lot more force coming up specifically into the knee joint and the IT band in that position. So downhill running can create more issues when it comes to IT band syndrome. Now we get into some of the biomechanics here. It can depend on the person as well, right? Depending on your running form. So we typically get that IT band to be in the right position, right in that lateral portion of the knee where it's compressing the fat pad at about 20 to 30 degrees of knee flexion, so where that knee is bent. So depending on how you actually strike the ground, what position you're in, we can modify that in some way to take stress and compression off that area. Rear foot eversion at foot strike, those are the people that can, as you strike the ground, are in more of an everted or pronated position, right? We're not afraid of pronation, but are we over pronating? Are we going too far in that position, which tends to cause a cascade of events up the chain, knee valgus, pelvic drop, those things which really cause a lot of stress at the lateral portion of the knee. Some of these things I kind of just talked about here: knee valgus, hip abduction, is that leg landing too far underneath the body as you strike the ground. Is the pelvis dropping? So if I'm standing on my right leg and stabilizing, is my left side level with, or am I dropping through that left side pelvis? And then also what we have seen through some research is trunk lean as well. So as we start to see some of these things, you'll notice the tendency for the body to lean over that stabilizing side. So if I'm striking the ground on my right leg, but I'm more unstable, my trunk is actually going to lean over that side to a degree to help create a more stable environment. Okay. Weakness has been shown, very conflicting throughout the research. Is weak hip abductors part of the problem here? So we're talking about the hip abductors, or the glute medius, glute minimus muscles specifically. A little bit conflicting. Some studies said yes, some studies said no. However, there's really no consensus saying, again, this is something we need to really think about. It's what we see through some of the rehab programs that were studied. Okay, these things do help, and hip abduction strengthening does help. Fatigue also plays a role. So as you get later in your runs and you start to break down, you start to get a little more tired, you start to change how you're absorbing force, position of your body as you go through that running cycle. We do see that this tends to create more problems later in a run rather than early on. Most people kind of hit that point, right? That threshold, that crossover point. Hey, I can run 3 miles, no problem. But once I hit that point, my knee starts to act up. So there could be some kind of fatigue component there as well. Now, these are just some pictures I put together just to show some of the risk factors in action here. So we see in the top left here, and pretty cool picture, I think. But running, downhill running, you can see more specifically the woman in the back there, just kind of reaching for that next step, because obviously it's a lot further, the ground's a lot further away from her if she was running on flat ground. So that creates a lot of stress up from the heel directly into the knee and IT band. So a lot of downhill running increases the risk of IT band syndrome. Now, if we look up here, this is on the top right, we're looking at rear foot eversion at foot strike. So you can see the difference from his left foot to his right foot. Greater collapse of that right ankle and foot. He's going into more of an everted or overpronated position. That's something there as well. Bottom left, we have a mix of knee valgus, right? The position of that knee as he strikes the ground, absorbs force, that knee tends to collapse in. And at the same point, sometimes these go hand in hand, but not always. You can see that what's called contralateral pelvic drop. So I'm on my right leg, right, landing. My left side pelvis is actually dropped lower. This is just a loss of stability throughout the pelvis and hip. Then if we look at this one right here, this is the trunk lean I was talking about. So if we have poor stability down the chain somewhere, whether it's the foot, the knee, hip, or pelvis, you can see the body has a tendency to compensate and lean over that leg just to be in a more stable position. If the body was following the alignment of the pelvis, right? This person would be kind of really leaning over to the right side, and it's really hard to hold your position. You're landing on the right leg, you're really tilting to the right side, all your momentum is kind of going off that way. So we tend to shift to compensate. Then on this last one, obviously not showing hip weakness, but possibly hip abductor weakness. So making sure we're doing a good job strengthening these muscles from the outside of the hips, hip abductors, glute medius, those muscles with typical band exercises or single leg side planks can be helpful there. Now, the big question, can we actually stretch the IT band, right, to resolve pain? So through the research, you see that stretching is the most prevalent treatment for IT band syndrome. When they look at sports med professionals, PTs, chiropractors, docs, stretching was really the number one thing recommended when it comes to IT band syndrome. And for those of you who looked in the Facebook group, I believe last week I showed an image. They actually have taken IT bands out of cadavers and inject whatever fluids to make it skin as natural as possible, but hung the actual IT band up, held a weight to it on the bottom to see at what point can we actually stretch this tissue. A lot of these studies refer to the IT band as soft steel. It's soft because we can push into it like in healthy living tissue, but it's steel because it's so strong, right? It takes a lot of force to actually deform and elongate that IT band. What they believe is any lengthening that you tend to get from stretching this is actually coming from the muscular region of the hip. So the glute maximus muscle, the TFL muscle, which I showed originally here. Some of these muscles up here are usually where you're getting that lengthening, but it's typically not actually the IT band itself because it's too strong of a tissue. So what they showed through the research, the human IT band can withstand substantial tensile forces, and actually like stretching of the IT band only falls within what's called an elastic range. So if we think about elastic band, that elastic band can stretch, but as soon as you let go of that stretch, it comes right back to its original position. We have a difference when we talk about flexibility and range of motion. We have elastic, and we also have plastic. So elastic stretches and then recoils back. Plastic, we stretch and then it holds that position, right? That means I'm actually increasing the length of the tissue if I'm getting plastic changes in that tissue. However, we just are unable to provide as much force as necessary to actually stretch the IT band. So when someone says, hey, you have IT band pain, you need to stretch it, your IT band's too tight. Maybe it's tight. I don't know. We know through the research you can't stretch it out because it's too strong of a tissue anyways. So we need to get away from this notion of, hey, I'm actually stretching out my IT band. Yes, you're stretching all these structures on the outside of your hip, but most likely the IT band is not lengthening in any way, right? What we did see through some of this research, even though we're not increasing actual length of the IT band itself, it's not getting longer. Stretching does help to a degree from a pain reduction standpoint. We're not sure what it's improving. Is it more flexibility of the TFL or the glute muscle? Is it just putting the tissue in that position, which helps reduce pain? But a lot of the research on stretching shows it reduces pain. But from another standpoint, it does not actually increase flexibility or length of the IT band. So making sure you're accurate with how you describe that to people. When people say, hey, when I had IT band syndrome, I just stretched it. And as it became, my IT band was more flexible, my pain went away. That's probably not the case. Now, should we foam roll it here? And I made sure to include this quote from the research because I know I've talked about foam rolling a lot in different capacities. So making sure that you kind of see where I'm pulling this information from. The results of the current study suggest that foam rolling over the glute muscle is an effective means to improve an immediate measure of passive hip abduction. So what passive hip abduction is if we look at, show you guys so you can see it. So adduction means if you're standing here, that leg is being able to come under the body, which we think of as lengthening that IT band. So actually foam rolling the glute muscle helps improve flexibility of the hip in that direction. However, and this is what we find with other studies on foam rolling of muscles specifically. However, a single bout of foam rolling over the IT band did not produce an increase in range of motion. So if you foam roll the hip, the glute, it improves range of motion, but not the IT band. And what they found through the research was that different types of tissue respond completely differently. Some of these more muscular type tissues like the glute, like the quad, calves, these areas more easily respond to foam rolling. However, such a thick, dense piece of connective tissue like the IT band that's so, again, firmly attached into the femur. You can roll that all day long, but it's not actually improving range of motion or lengthening throughout that range of motion as opposed to the glute muscle. So should you foam roll the IT band? Maybe not. You can do it. We know there's some research out there that shows that foam rolling for 10 minutes can reduce pain for up to 30 minutes. We can see some improvements from a pain reduction standpoint, but making sure we realize as we foam roll the IT band, we're probably not making it more flexible in any way. We're probably not releasing adhesions, all those things which are usually thrown out there way too much. But it might be potentially helpful from a pain reduction standpoint, but not from an overall range of motion and flexibility standpoint. Okay, feel free to look into that one right there is the actual article itself at the bottom. I thought was super interesting. Now, question is, what do we do, right? What do we do moving forward? So there's some basic rehab and treatment recommendations. Research shows that a 6-week rehab program involving anti-inflammatories, stretching, hip abductor strengthening have been shown to be effective. So again, which one of these things? Is it one of them? Is it the combination of all of them together? Not sure, right? They didn't do a good job of really teasing these out to see what was the most significant throughout that rehab program. But conservative therapy, right? If we're trying to treat this not in a non-surgical way, so rehabilitation, some kind of treatment, manual therapy, IT band, it does take some time to resolve. So 44% of people are able to return to sport within 8 weeks. 91% of people are able to return to sport in 6 months, right? So that's why typically if I see someone with IT band syndrome, I typically tell them, hey, this could maybe take up to 4 to 6 months to get better. It can be a little bit more tricky to resolve. So understanding that, again, half of people or 4 out of 10 people resolve in 2 months, 9 out of 10 people resolve in 6 months. It's a pretty big range there, but it could take some time to fully resolve. And that doesn't necessarily mean you're not running, you're not active, you're completely resting, but you could be doing some kind of modified workouts for the time being. Rest is helpful for acute cases. So that's why, and I think it's important to understand the difference between an acute injury and a chronic injury. Acute, again, this just happened, right? This just happened today. This just happened yesterday. You're somewhere within, again, 4 to 6 days of that initial injury. So if that's the case, resting actually is very advantageous at that point, that we don't continue to irritate that fat pad and that tissue between the IT band and the knee joint. But once this becomes chronic, rest is really not as helpful. We need to make sure we're addressing the biomechanics. We're looking at running form. We're progressively loading the body. So making sure at that point it becomes more of a physical therapy rehabilitation type approach rather than, hey, my IT band's been bugging me for 4 months. I'm going to shut down for a week and then get back at it. Typically, those people that do that, they stop, they rest, they feel great once they rest, they get back to it. They didn't actually address anything in the process that's predisposed them to that pain. And then they're right back in the same situation while just feeling a little bit more rested in the process. There needs to be more research on taping, orthosis, and gait retraining. I have seen through some of the research on gait retraining, looking at cadence specifically and preventing overstriding. So we don't want that leg to land too far out in front of the body center of mass. And if we can increase cadence or increase our step rate, get that foot to pull in a little bit more, to land underneath the knee, change how our body is distributing force, we can reduce a lot of that stress to the outside of the knee and IT band. And obviously in cases where you don't see good results, again, after an extended period of time, 6, 12, 18 months of conservative therapy, again, considering surgery, which actually has really good results. But usually all the research shows that surgery is no one's first step in this process. They always exhaust conservative therapy first, and then they go to surgery second. Now, just to show you some specific exercises, right? We talked about hip abductor strengthening. Looking at here with the straight leg out to the side, kind of activate, engage through that glute medius, right? These muscles on the outside of the hip are what help stabilize the leg, which help absorb force at foot strike and also stabilize and keep that pelvis level. So this is just a simple neuromuscular drill where I'm trying to teach myself how to fire and feel those muscls. A very simple starting point. Next up here, where I try to get most people to go, getting into some type of single leg side plank exercise. Want to be able to hold this for a minimum, just holding, not lifting and lowering. This is what I do to train and to build strength here. Be able to hold the single leg side plank for 20 seconds per side. That's per the research on having enough hip abductor strength, but making sure you're progressing your side planks if you're someone that's doing side planks to build up to this. I mean, that's super helpful when it comes to rehabilitating or preventing IT band syndrome. Next up, we're looking at a hip hike from a deficit. So you can see him standing on a weight plate, I'm trying to teach myself how to position the pelvis and teach myself that that pelvis actually moves, what's called the frontal plane, right? Side to side motion, up and down. We need to really learn how to better appreciate and to control this position, because once we start dropping through the pelvis, that's where we create, and the tendency for the hip to rotate in, the knee to collapse, the foot to collapse. It does create this cascade of events, which does load more into that lateral portion of the knee. So teaching hip hikes, lateral toe taps, another great exercise. So here, trying to make sure, keep the pelvis level, keep the alignment of the knee. As this band stretches, it's trying to tug the knee inward. So I'm trying to maintain alignment and stabilization as I move out against that resistance, right? So just good single leg control here. Making sure at all times we realize that we need to do a better job of bridging the gap from traditional rehab and PT to performance. Running, literally jumping and bounding 2 to 6 times your body weight as you come down. So one of our final steps before we actually get back into running needs to have some type of plyometric demand. So as we land, this is a depth, I don't call it depth single leg landing. I'm stepping off the rower here. I'm landing on one leg and I'm absorbing force. If we go back to the original risk factors, landing with the knee bent 20 to 30 degrees is what increases our risk of injury. That's kind of the range where the IT band tends to be more, or the fat pad or whatever it is, more irritated. So making that one of our final steps, we need to be able to accomplish these things under force to make sure we can stabilize, we can control the foot, the knee, the hip, the pelvis, and land properly without experiencing pain. So this is usually one of those kind of final steps of rehab. And then lateral line stretch, I like to call it, or IT band stretch. Like I mentioned, we may not be actually stretching the IT band itself. We probably are not going to get much length from that thing since it's so strong. However, the research shows that the stretching with the strengthening, with the anti-inflammatories, these things. So I wanted to make sure I at least showed you the IT band stretch. I'm simply going to put the leg behind the back, arm up and over. Again, not sure if it's actually what it's doing. It's not lengthening the IT band in any way. However, it could have some type of pain relief mechanism behind it, but obviously still needs to be studied. Now, as we wrap up here, I want to wrap up in the next couple minutes or so. Feel free, if you have any questions, feel free to drop them in the chat box there. Just simple take-home message. If this is something that happens to you acutely, you're running and wow, that IT band really hurts, that lateral portion of the knee, resting in some anti-inflammatories has been shown to be the most helpful in an acute case. Once this is chronic, you need to really understand your running. In both cases, understand your running. Reduce mileage or intensity, or understand what did you increase that maybe predisposed you to this. Make sure you understand those variables. Look there first. Address biomechanics. So is there anything from a running form standpoint you can do to, again, reduce stress on this area? Cadence is one. Again, increase cadence by 5% can reduce the stress at the knee up to 23%, right? So that's huge, just by getting the legs to turn over more quickly. That's probably the first place I would go. And then obviously also adding some kind of progressive resistive exercise. How do we load this area, load the surrounding tissues to build up tolerance to load, to improve strength, improve stabilization? There's a lot of different things we need to consider, from the foot all the way up to the core and spine. Expecting about 2 to 6 months. Again, if you're addressing this, right? A lot of people always say, hey, I've been dealing, you said it was going to be 6 months. I've been dealing this. I've already been dealing with this for 6, but you haven't been doing the things that actually address it, right? You're just starting right now. So it could take 2 to 6 months from now. Understand it does take time. Should you stretch it? That's completely up to you. Without putting my opinion in here, right? We see through the research, stretching may not actually increase length of the tissue. So why are we stretching something that's not actually going to lengthen? Does help from a pain relief standpoint. So if you want that, try it. Should you foam roll it? Again, completely up to you. Foam rolling has been shown to have a pain reduction benefit to it. However, because it's such a thick and dense and strong piece of fascial tissue, most likely when we're not releasing adhesions, we're not realigning fibers, we may not get any added length or flexibility from foam rolling and stretching. So that's something you like to do. Go ahead and continue to do it. If your goal is injury prevention, to reduce the likelihood of injury at the IT band, you need to run smart first and foremost. Again, look at your running and your training program first. Like I said, about 60 to 70% of running related injuries are due to training errors. So make sure you're following a nice structured and periodized program that's designed for you. And then at the same point, hopefully address running and biomechanical risk factors just to be as efficient as possible as you run. Do we need to be perfect? No. You can run smart, I think, without addressing anything else in the process and still do fairly well. But if you want to cross over to the next thing and getting a running analysis done, getting an evaluation, incorporating a strength training or some type of injury reduction program, would kind of be the next piece of the puzzle to really take things to the next level. All right, guys. So let's wrap up here. Any questions right now as we wrap up? Just so you guys know, I will be sending the replay of this tomorrow at 11 a.m. Eastern time. Have the email ready to go. Just going to add in the link to the video, but hope this helped you in some way. If you can, feel free to pass along if you know someone that's struggling with this. Start using some of those exercises on a regular basis, add them into your program. They could be good from either a rehab or injury reduction standpoint. But really kind of digging into this, since it can take 2 to 6 months, making sure you're getting on top of this now rather than waiting. We don't want to rest if it's something that's chronic. Get on top of it now, do the right exercises, get back to running it as soon as you can. But I hope you guys enjoyed the presentation today. Thanks, Stormtrooper, aka Jessica, everyone else. I appreciate you guys joining. Hope you have a great rest of your Tuesday. And that's it. Thanks once again.